says, I know one of the issues with malaria treatment is the appearance of strains that are resistant to currently available drugs. Is drug resistance also a concern when treating parasitic worms? Have any cases of drug resistance been found?
Oh, it's a great question. Yeah, well, malaria is a parasite, so yes, that is a concern with certain parasitic diseases. It hasn't been so far for these filarial worms, but it is something that's people look at. But malaria, it certainly has been a very big problem.
So there is a question left over from yesterday's meeting that I think relates to what we're talking about today, and it was, how are the challenges in achieving health equity different now than they were early in your career?
Yeah, I this is such an interesting, great question, by the way. I think that the issues in health equity are sadly still very similar today that they were, when I started out in public health. But I think we're beginning to recognize them more. So we have a new CDC director, Michelle Walensky, and she's really enthusiastic and great to have her. And she just did a staff all hands meeting, and she came from Mass General Hospital. She's a clinician, infectious disease expert, HIV expert actually, and she was pointing out for the agency how COVID, the remarkable racial ethnic disparities there are with COVID-19, how terrible it is, how we have to address them, and how should we need to be thinking about how to address these. And the interesting thing is, it's true, there are huge discrepancies in COVID-19. And maybe the silver lining about COVID-19 will be realizing that these discrepancies exist in every disease we deal with. This is not new. I mean, this is true in HIV, it's true in cardiac disease, it's true in tuberculosis, true in chronic diseases. In every single disease we deal with, there are big racial ethnic disparities. I mean, a big one is maternal mortality and infant mortality that we hear a lot about. And so I think maybe that this will start us as a community beginning to think more strategically and in a bigger way about how to address these and really get at health equity, which isn't about personal risk factors or about genetics. This is really about structural issues that we deal with in our society that affect health access. So it could be access to health, or it could be just living in neighborhoods that are either very stressful or don't have access to good grocery stores or to pharmacies, or it's a lot of things. But these are, a lot of times we kind of think, oh, bad genes, or oh, you shouldn't have eaten that. But that isn't what it's about. It's really structural issues that lead people to not have choices in some communities versus other communities. So yeah, I guess to answer your question, I think the equities, the disparities are still there, but hopefully we're looking at them a little bit better, and kind of realizing also that race it's a construct. It's not, what's it measuring? Maybe it's measuring access. It's measuring these structural factors.
You remember Congressman Johnson called a Senate hearing, I believe, about ivermectin, and he had some physician there talking about that as a panacea for COVID cure, and I never heard anything more about it, as he apparently professed that it cured any large number of people in a number of countries. What can you tell us about that, Mary?
Oh yeah, such a fascinating question. So there are some data that suggests that ivermectin may be helpful in treating people who have COVID-19, but I think that the reality is the data are still out. It's kind of like hydrochloroquine. There are some suggestive studies, but in the real world, will this lead to anything important. And I think we just have to be careful, to have the studies. The thing about drugs is there isn't any free lunch. So for ivermectin once a year, it's a really safe drug. But if we're talking about treating people with large doses over time, we really don't know how safe the profile is. So there are studies underway, population-based studies in some countries, but the data aren't yet available on whether this is an effective therapeutic. I mean, it'd be nice if it were, because it's available, and it seems, from what we know from short course treatment, it seems to be pretty effective. But we just have to be really careful not to ever, recommend something that hasn't been carefully evaluated and it hasn't got a really good safety profile. So that, that's the thing about every intervention. If an intervention doesn't have a negative effect, like masks, I feel more confident to tell people, well, we know they work, but before we knew they worked, I would feel more confident saying to people, well, we don't know if this is effective, but I don't see any reason why, you shouldn't use it, because it's really safe. But with a drug, we can't be so certain,
Also, if we redirect our supply of this drug to COVID cases, then we're taking it away from the NTDs, which is going to be devastating in the long run for those people too, right?
That would be very hard. That's a really good point. Yeah.
Question about the dogs with guinea worm.
Uh-huh.
Do they also have the worms mechanically taken out, or like? That would be. Yeah.
And it's not really pulling. You can't pull them or they break.
It's rolling, right? It's like a centimeter a day if you're lucky.
Yep.
Right. Yeah.
Mm-hmm.
How has the CDC changed as a result of changing administrations?
Yeah. Well, we have a new director there named Rochelle Walensky, and she's been really a nice breath of fresh air. She's pretty young. I think she's in her early 50s, and has been working at Mass General as she's a infectious disease chairman of infectious disease there. So it's nice to have somebody who was very active in the field and has a real passion for communities and really has been out in the community bringing kind of like new blood for the agency. So that's been great. And the CDC has administrations differ in how they cover things, or how they want their agencies to support them. And one thing that's changed is that CDC now is out in the forefront more. Dr. Walensky or one of the CDC senior leaders provides an update every day. And before, in the last administration, it was really left up to the White House to provide those informational updates to the general public. So I think it's good to have CDC providing a clear message and updated information. So I think the agency's been a little bit more in the public eye in this administration. But administrations vary in how they handle things.
How did you transition from the idea of working as a physician to working primarily as a medical scientist?
Yeah, that is such an interesting question. It's a difficult one, because I really like being a clinician, and I think a lot of people do. I mean, some people really think that they want to be in public health, but there are a lot of people, both when I was getting my degree at the University of Washington, Master's of Public Health, and also at CDC, who really do see themselves as clinicians. So the problem is, because there's only 24 hours in a day, you kind of do have to pick something to be focused on. And I obviously, put most of my focus in public health. but I wasn't really willing to give up being a clinician. So I've maintained, I am on staff at the Veterans Administration Hospital in Atlanta, and I see patients. I have a group of patients that I see once a week on Friday mornings, and I work now just with people with HIV. So I don't, so it's a more discrete group of people that or a group of diseases that I need to be familiar with. It's hard to stay on top of everything in medicine these days. So my focus is really just HIV these days. So it's difficult. I think it's difficult. You have to choose. I try to have both, but it's hard.
Somebody asked, how would you have handled the US's response to COVID-19?
Well, it's pretty easy to retrospectively go back and say, oh, you did all this stuff wrong. So I don't know how I would have handled it, but I think we do have a lot of experience in outbreak responses that can tell us about what the most effective responses are. And responses are organized. The most effective responses are very organized and transparent. They try to get messages out on a routine basis to scientists and to the public, and try to be evidence-based. And when evidence doesn't exist, be very honest about where the evidence is still lacking and where we need to find out more data. And try to be honest about what we don't know, because otherwise we lose the public trust. So we really need to, be out there, talk about what we know, talk about what we think. If we don't have the evidence, what experts think are the most important things, just to give people options to stay safe. And I think that an organized, consistent response has been shown to be effective in other outbreaks that we have had. Mm-hmm.
There was a particularly specific question about what is the status of PEPFAR. I think you kind of addressed it in the Q&A yesterday, but I perhaps will record a response here in case others are interested.
Yeah, that's a great question. So PEPFAR is the President's Emergency Plan for AIDS relief. So it's the U.S. support to countries that are hard hit by HIV. And it focuses its support on countries that have high HIV prevalence, but not very high per capita incomes. So there are quite a few countries that are supported by PEPFAR. And the program was actually started in the Bush administration, and it's really a very, very large amount of money that supports countries, especially in the areas of prevention, care, and treatment, with a focus most recently on treatment. And through PEPFAR, many countries have been able to provide antiretroviral drugs to people who are infected with HIV. It's been a huge response and really a huge success. Just getting people on these life-saving drugs has been great. So PEPFAR continues. It's a congressional. It's budgeted. It has a line item, and actually the U.S. coordinator for PEPFAR was Dr. Debbie Birx, who was, pulled into the COVID response, the White House COVID response. So she's the U.S. ambassador for PEPFAR, and I don't know if she's continuing to be while she's working in the COVID response. I know the one of her senior deputies, Anjali Ashrikar, is the acting person, but I think it's a presidential appointee, so we'll have to see who will be in charge of the program in the future. But it involves several of the agencies. The CDC is involved, and USAID, and I think State Department. It's a big effort in many countries.
And then I think I want to capture your response for students to the question, is it common for those pursuing a career in public health to get an MD, or what is the most common degree or professional path? I think your commentary about the art and science of public health was particularly illuminating for me. So if you don't mind rehashing that, that would be fantastic.
Yeah, that's a really interesting question. So I don't think most people who are in public health necessarily do have a medical degree. Many people do, but they're, because public health really is covering more than just diseases or infectious diseases. We have to think about the broad range of things that affect public health, and so people from all aspects of all different disciplines are really helpful. So there's issues about personal risk behaviors. So social scientists are very important, and about the infrastructure and access to health. So people with political science degrees or law degrees are very important. So of course, laboratory technologists or laboratory scientists are really, really important in public health. And people with diseases, with degrees in veterinary medicine, a lot of diseases are zoonoses. But I work with people who have backgrounds in anthropology, who did undergraduate degrees in classics or in philosophy. I mean, all of those are really important. So yeah, definitely. In fact, I suspect that most people in public health these days don't have a medical degree. I think most may have, background in some kind of degree that involves some statistics, but I don't think most people don't have a background in medicine. And in fact, getting at that response side, there's the public health research and there's also the response. There is a kind of a category of public health workers called public health advisors, who have a background in almost anything. And those are the people that go out and do contact tracing and are really working right with communities on response. And they are the people who organize and do the logistics and do the oversight. And those are critical to public health. The public health advisors are just a huge important element of public health.
We see more interest in global health now than ever. How can we leverage this interest to achieve real change that improves lives?
So that's a really interesting question. I think we see interest in global public health, and we also see a lot of funding for organizations, not just bilateral nations, but also foundations like Bill and Melinda Gates Foundation have provided, big opportunities in global health. And of course, those agencies have put a lot of thought into how they can have the biggest impact. And I think that, it's certainly an area that people are putting a lot of thought into. And I know, for example, the Bill and Melinda Gates Foundation thinks very carefully about thinking about plan and intervention availability and impact and just certainly planning things out very carefully before going forward. I think that there have been a couple, impact is a big thing, and there have been a couple things that have happened. They're not super new, but more recently in my career. And one is the development of a different kind of measure called DALY, or disability associated life years, and QALY, which is quality life years. So looking at these kind of measurements kind of helps pit interventions, compare interventions against each other. So that's something that doesn't seem to be, like take something like HIV, the intervention is very effective, but it's very expensive. And maybe it might turn out that something, as cheap as once a year mass drug administration if you look at something like disability affected life years lost, is more cost effective and more impactful than putting all your resources in HIV. So I'm not sure that's always the case, but there's different ways of looking at things that can help us understand, where's the biggest bang for the buck, or where's the biggest impact. And another thing about global health that's changed since I started that's kind of interesting is looking at unintentional consequences. A lot of times programs started and it seemed, obvious this would be a really important thing to work on, but might have had unintended consequences that that perhaps could have been foreseeable, but weren't considered before the program was started. So I think people are really looking very carefully at benefits and risks, which I think is good. Yeah.
I thought you asked, what do you recommend for, or you answered, what do you recommend for a student interested in going into global health next year? Was that, did you cover that yesterday?
I can't remember, but I can answer it again. So
Okay.
I'm delighted that somebody would want to go to global health, because I think we need new, fresh blood and new ideas. And I don't know if I can make specific recommendations, but I think reading a lot and reading about some of the programs historically is helpful in understanding what you might be in for in a career, and what are some of the things that maybe are most interesting to you, because there's so many ways that people can contribute in global health.
A piece of advice for Gonzaga pre-health students.
Oh, good luck. I'm not sure I have advice, but good luck. I think that's great. Major in something you're passionate about and go for it. I think it's wonderful. I'm really glad to hear about people going into health.
How has friendship helped you in life?
Oh, friendship has helped in so many ways. Actually, just before this talk, I can't tell you how many email I got from friends who were like, "Oh, go for it." They were just so supportive. So for me, friends have been both supportive, and I've Gonzaga friends actually, and also. It's just great to work with people from a lot of different backgrounds and have a lot of different ideas, because that is it so informs what we do. My biggest concern is that I get into a bubble and I might not be aware of things that are important, but I just have blinders on and haven't seen, or just different ways of looking at problems and different ways of looking at things. So yeah, friends are great.
What do you recommend for a student interested in going into global health?
Yeah, well, I'm really glad that someone would want to go into global health. It's we need new blood, young blood. It's really good. I just read a lot, and I think sometimes reading kind of the stories of programs that have gone on before and what the lessons are is really helpful. I put a few references up there. One that I really like is that isn't up there actually is the story of smallpox eradication by Bill Foege, who's an ex-CDC director, and he was a early smallpox warrior. But I wish people well. I mean, maybe the other thing is don't be too stuck on your life plan, because there are opportunities that come up and you want to go ahead and take those when you have them.
Do you think the US would have done better if the epidemic or the pandemic, if there had been a more centralized response rather than state by state?
Yeah. Well, I think that a strong national response is always a better approach. Yeah, absolutely. I mean, we got in a situation where the states are almost vying with each other for some commodities like personal protective equipment. So absolutely, a strong national response is very, very good in any kind of epidemic.
Another question related to a relationship with the WHO is, would you have been able to work on WHO projects if the U.S. had withdrawn from the WHO? Like that period of time when we'd pulled out, how did that affect that collaboration?
Yeah, that is really interesting. So, I mean, I would say, I've spent a lot of my career working in global work, and most people at CDC do work domestically, but there is one center that is primarily global programs like global HIV and malaria and neglected tropical diseases and so forth, TB. Um, we have the agencies are so collaborative and connected that we were in a really tough situation because fortunately there was a long period of time before we would have withdrawn, but we have probably 35 CDC staff that are seconded to WHO and are leading programs. I mean, people who lead some of the big programs are actually CDC assignees at WHO. So of course that would have made a very, that would have been very problematic. And one of the reasons for that is WHO it's helpful for us. It's helpful for the United States when we're, part of this big global response. And WHO is really underfunded. I don't think it's fully appreciated how underfunded this agency is, which really is a normative body. I mean, there isn't any country in the world that doesn't look to WHO for guidance. We also at CDC have, I think, 35 laboratory collaborating centers with WHO where we work together. In my particular group, we have one for guinea worm and we have one for trachoma. In my former work, we had one with sexually transmitted diseases. And I don't know what would have happened. I mean, we would have had to break all those some of them have been going on since, our guinea worm collaborating center has been going on since 1980. So that would have been really difficult. We were all kind of holding our breath, I think.
What are the pitfalls of work in global health that keep us from achieving the change that will lead to real improvements in people's lives?
Yeah, so many pitfalls, Well, you saw some of them, but I think that, I think there, not having a good vision or an objective up front or being really clear on what needs to be achieved is a pitfall that we see repeatedly. And I think when programs go out and try to do something, having to get together the funding that's needed to do it right is a pitfall. I think obviously, for any type of global work, it's really supportive. I mean, the country is in charge. It needs to be supporting what the vision is that the country has. And sometimes I think in the West in particular, we have an idea that we'd like to, help country X get rid of this terrible disease, but they have a lot of health priorities that they're juggling at the same time. And what we think is the disease that we want to work on may not be their health priority. So we really need to think about that. And that actually has kind of been a lesson learned from polio. Polio is a terrible disease. It maims a lot of people, but in some countries, that's not their primary disease that's causing disability or death in children. So a lot of big countries like Nigeria and India came on late, and that has made it more difficult to eradicate. But pitfalls, so many pitfalls. Yeah, just learn from lessons, I guess, to learn.
One of our majors just asked if an MD was the common sort of degree path for public health, or you did mention earlier about it being science and art. And so to what extent can students have a more liberal interpretation of a potential path into public health?
Yeah, that is a great question. So, so a lot, I would say most of the people that I work with at CDC are not medical doctors. Now that hasn't always been the case, but a lot of the people I work with are epidemiologists or laboratory scientists or social scientists, veterinarians. So there's a number, anthropologists, number of different pathways that people get into public health, and they're all, you know, they're all useful because there's so many ways that there's so many different things that we have to think about with public health, you know, health in communities. It's all of those things, you know, we talked about, not just infectious diseases, but all sorts of things.
Somebody was curious about your opinion, or even maybe the emerging opinion coming out of the CDC regarding the origin of the COVID-19 virus.
Well, I can't talk for CDC.
I know,
but I can tell you, yeah, for me, this is Mary Kamb's opinion. I don't know. You know, there are a lot of suspicions that this might have been a laboratory accident. And you know, the interesting thing about that, Bill Foege, who's I'm not sure I mentioned, but he's a former CDC director. He was talking about, you know, back the EIS program was started after World War II because people were afraid of biologic warfare. And it turned out that biologic warfare wasn't our biggest concern. And Bill Foege was visiting China a few years ago, and they started a similar program because they thought the United States was using biologic warfare. So I don't really think that scientists in general, you know, it could happen. I'm not saying that's not possible, but I would imagine that this was a virus that jumped species, and the Wuhan market was a super spreader event. So I don't think it came probably initially from the Wuhan market, but I think Wuhan was a super spreader event. And there's plenty of ways that coronaviruses can jump from species to human.